Hello and welcome, David and Liz. We'll give it a moment to let you get connected to audio. All right. Welcome. Thank you for being here on time today. We really appreciate it. Jacob, did you want to wait 1 to 2 minutes to see if we get more participants in the room?
I think that would be great. Yeah, let's give some more time for folks to join.
Perfect. All right, I see them coming in. We'll also give them a moment to get connected to audio as well. Welcome, Jeff. And I see Teresa getting connected to audio. Perfect. Welcome, Teresa. Thank you for joining us.
Thank you.
We're just giving it a minute to let participants get signed in. All right, Jacob, I'm going to pass it over to you. Thank you.
Thanks, Misty. Welcome everybody to our Funky Bug lecture for today. Really appreciate everybody taking time to join our lecture this morning. You may have noticed in some of the marketing materials that have come out or through this presentation that we're making some changes to this series. So a lot more to come. And if you have any questions, ideas, or suggestions for us, we'll talk a little bit about that at the end. But for today, I am pleased to introduce Dr. Martina King, who is Assistant Professor of Medicine, as well as an internal medicine hospitalist here at Denver Health. Today, Dr. King will be presenting on cholera. I think without further ado, I'll hand it over to Dr. King.
Thanks, Jacob. Thanks for having me. And thank you guys for coming. I'll start off by saying that though this is a series on infectious diseases, I'm not an infectious diseases specialist. I'm an internal medicine doctor. So just wanted to clarify that lest you be disappointed. We can go on to the next slide. So thanks for coming. We're going to talk today about cholera, an Oregon Trail disease, a disease of antiquity, something that we never talk about here, which still affects millions of people around the world, including large outbreaks that have happened within the last few years even. And this is a lithograph of the disposal of dead bodies during an epidemic of cholera in Europe in the 1830s. And I included it because I think old art is fun and to remind us what a high mortality disease this is if not properly treated. And lithographs are cool. They're prints made by using acid to erode into a piece of stone, and then you can create multiple prints of that same image, which is neither here nor there. Next slide. So cholera has probably been described as far back as the 5th century BC in India and the 4th century BC in Greece. So there are writings from those times from Sushruta Samhita in the 5th century BC in Greece and Hippocrates in India and Hippocrates in Greece that probably describe a disease that was probably cholera. And then more certainly the first epidemic was probably described in 1543 in the Ganges Delta in India and Bangladesh. And that's an important place, the Ganges Delta, because it's thought to be the origin of cholera in general. So the Ganges River empties out into the Bay of Bengal in that area that's circled there in gold. In Bangladesh and in modern day India in the state of West Bengal. And that place is a low-lying, wet, very fertile area that incidentally is quite affected by climate change. and is thought to be the origin of the cholera bug. And it's important, we should maybe remember that that's a place where a river empties into the ocean. So the delta, the Ganges River, empties into the Bay of Bengal. And that's important because, as we'll discuss a little bit later, cholera thrives in water that's sort of mixed, salty and freshwater, called brackish water. So since the first detailed epidemic, there have then been 7 described pandemics. So if you remember, a pandemic is a worldwide distribution of a disease. So the first pandemic originated also in the Ganges Delta in 1817 and spread through other portions of Asia and into Europe before it finally died out in 1824. Next slide. So after that, there were 5 more pandemics that all originated in the Ganges Delta. And we won't talk about them in detail, except I'll mention that the third is probably the most deadly. And beginning with the second pandemic, there was spread into the Americas. There were these other pandemics, each one sort of erupting, affecting multiple places with multiple outbreaks or epidemics within. And then most recently, the current pandemic, which is still ongoing, is the 7th. It began in 1961 and was the only pandemic that did not begin in India. This one is thought to have begun in Indonesia, which isn't really that important because it has spread all over the world. There have been multiple deadly outbreaks, large and deadly outbreaks of this current pandemic of cholera. Some of the most notable were in Zimbabwe in 2008 to 2009, which I think was the most deadly. In Haiti in 2010 to 2011, which might be the most famous. And also, I didn't note on here, but in Yemen more recently, there was a very large outbreak. The one in Haiti occurred at a time of political instability when the United Nations had security forces in Haiti. And there hadn't been any cases of cholera in Haiti in a very long time. And then it has been shown epidemiologically that unfortunately security forces inadvertently imported cholera into Haiti, causing that epidemic. That's why there were these political protests, like you can see in the image there. So we're currently in the 7th cholera pandemic, and there are outbreaks ongoing throughout the world. Next slide. So if you guys don't Google because it's no fun, but if you think you know what cholera is, type it in the chat. There's no test and there's no grade. Okay, next slide. Evil humors is the answer. No. But it was thought for a long time that it was caused by insects or like a change in the Earth's magnetic field in some way. I didn't read very much about that. But in fact, it's a bacteria, a gram-negative rod called Vibrio cholerae. And Vibrio cholerae has over 200 serogroups, but only 2 of them, serogroups 01 and 0139, have been shown to cause cholera as we know it. And within those serogroups, there's only certain strains that produce toxin, and only the strains that produce toxin cause cholera. So there are non-toxin producing strains of those serogroups, and those can cause other types of infections, including diarrheal illness and wound infections, but only toxin producing strains of serogroups 01 and 0139 cause the disease cholera. And remember, cholera is a gram-negative rod that lives in aquatic environments in brackish water, so salty, kind of fresh water, most commonly, although it doesn't have to be a place where there's ocean water. And the toxin is produced by a bacteriophage, interestingly. So actually a virus that infects the bacteria goes into its genome and causes it to produce the toxin. Within those serotypes, there are like further subtypes that we won't really discuss right now. Within those serogroups, there are further serotypes that we won't really discuss, but there's other ways of breaking it down, and different types have been implicated in different outbreaks. Next slide. So basically, people get sick with cholera when this gram-negative rod is ingested at a fairly high inoculum. So it takes a fairly large number of those bacteria are ingested, they have to survive the stomach acid, and some of them will not. So some will die in the stomach acid environment. Then they go on to colonize the small intestine. And there are certain things about the bacteria that make it more likely to colonize the intestine, like a pilus, a rope-like structure that's produced that sort of encapsulates the bacteria and helps it to stick to the intestine wall. It has a little flagellum that helps it swim through the intestinal lumen and then attach to the intestinal wall. So different properties of the bacteria help it to colonize the intestine. Then it produces that toxin. That toxin prohibits or inhibits the absorption of sodium chloride. So you end up having shifts then of water following the sodium chloride, water into the intestinal lumen, along with other electrolytes, namely bicarbonate and potassium. And the ultimate result is enormous amounts of fluid losses, including electrolytes via diarrhea. Next slide. So there are certain host factors that might make a person more or less susceptible to cholera. And perhaps the most important is immunity. People can acquire immunity through prior infections and also through vaccine. So there are a few vaccines that we'll discuss later, and they all confer fairly short immunity, months to a few years. And it's the same with prior infection. So it's not lifelong immunity, but people who have had kind of recent cholera infections will have short-term immunity. So in places where there's a lot of circulating cholera, you'll see the most severely infected people will be little kids because they haven't had a chance to develop that immunity. Whereas in places where there hasn't been cholera recently, like that outbreak in Haiti in 2010, you'll see everyone affected across age groups more equally because they all have a lack of immunity. Breastfeeding confers some protection, and it's really emphasized, especially in the developing world where this is an issue, that infants ought to be breastfed throughout the time of a cholera pandemic, including if the infant has cholera, and even if mom has cholera as well. And then there are a few things that are known to confer a worse prognosis in terms of host factors, and one of those is low amounts of stomach acid in the stomach. That is a high pH in the stomach. So remember that some of that inoculum that you ingest is killed by the stomach acid. So if there's less acid in the stomach, the person has a higher inoculum that reaches the small intestine. And that can happen from various factors, including medicines that we give people all the time, like proton pump inhibitors. Blood group O, for whatever reason, seems to be associated with higher mortality. And then there's some other genetic variations that are associated with higher mortality. Retinol, vitamin A deficiency is. And then there is some data, as you might expect, about the gut microbiome and how that affects people's susceptibility to catching and dying from cholera. And there are some microbiota that have been shown to confer protection, while there are others that have been shown to be correlated with a worse prognosis. Next slide. Epidemiology. So the most important takeaway here, as I mentioned before, is that cholera is a disease of dirty water, of contaminated water. It's a disease of places where there is inadequate supply of clean drinking water, where there are inadequate systems of disposal of waste, where there's a risk of the waste contaminating the drinking water supply, either on individual sort of family and community levels or throughout an entire larger community or urban area. People can get cholera from a kind of chronically contaminated water supply, or they can get cholera from more direct ingestion, fecal oral transmission, so inadvertent ingestion of the feces of somebody with cholera. And those feces are especially infectious sort of in the 12 to 24 hours following excretion. So people's diarrhea is especially infectious right when they're sick, and then that sort of drops off. Lastly, there's no animal reservoir for cholera. It's known to exist in water, and it's known to infect people and cause person-to-person transmission. There isn't an animal reservoir per se, but seafood, shellfish, excuse me, have this substance in the shells called chitin, which I might pronounce that wrong, but chitin is good for cholera bacteria to stick to. So one other way that people do get cholera, and it's less common, but there are cases where people get cholera from eating undercooked or raw seafood from places where the water is colonized. So there's kind of two different types of transmission, endemic and epidemic transmission. Endemic transmission refers to places where cholera has been seen within the last 3 years with evidence of local transmission. So communities where it's known to exist within the last 3 years and people are getting it locally. And then an epidemic can occur in an endemic location when there's a surge in cases, or an epidemic can occur in a non-endemic location when there's even one confirmed case. This picture is just, again, to illustrate the importance of water systems in cholera transmission. This image was taken in the Rohingya refugee camps in Cox's Bazar, Bangladesh. The right side of the image, you'll see like some fence posts, and those are usually the border, and then in from there, it's usually grass. So not water. So this entire area floods out during the monsoon season, and that causes a risk that the groundwater supply will be contaminated by wastewater. Interestingly, in some places, drought is actually associated with increased cholera transmission because there are fewer supplies of drinking water. So both drought and flood can increase transmission. Next slide. So again, cholera is a disease of unsafe drinking water, of inadequate sanitation. It happens in places where people are too crowded together with too few toilet facilities, or toilet facilities that inadvertently contaminate the drinking water, like refugee camps and slums, places where there have been disasters like earthquakes that disrupt the systems of waste disposal, or places where people have been relocated. London was like that in the 1850s. London was too crowded. London had contaminated drinking water. London had people living on top of each other drinking that contaminated drinking water. And in 1854, John Snow made this map of this neighborhood in London, where he drew little like dark colored black rectangles for every family or every individual or household, I think, with cholera cases. So you can see sort of in the center portion of the map, there are more little dark lines. And those are most clustered around a water pump. And the story is that John Snow asked the city to remove the handle of the water pump so people couldn't access it anymore, and then the cholera disappeared. The truth is that the outbreak was probably already peaked and decreasing by then, but nonetheless, he is credited with discovering this sort of drinking water source theory. Next slide. Okay, so cholera is a disease of poverty, of dirty water, of inadequate sewage and drinking water systems. This is a report published by the WHO showing the geographic distribution of cholera cases for the last couple of decades. So you'll see there, like the dark blue color is Africa, and the lightish beige color is the Americas, and the lightish blue color is Asia. So some places you'll read these numbers that the percent cases of cholera, the global percentages in Africa have decreased a lot. But really what it is that the number of cases in Africa is fairly constant, but that there have been big spikes in the Americas in beige, which was mostly Haiti in 2010, 2011, and in Asia in light blue, which was in large part Yemen in 2017 to 2019. On the left, they've written out a lot of zeros there. So in case you can't tell, that's 1.4 million is the top of the y-axis. And it's important to note that this is probably vastly underreported because of because of underfunded public health systems and ways of reporting in places where cholera is common. Some sources say that there might be as much as 90% underreporting of cholera. But in any case, there's underreporting, and these numbers are almost certainly less than reality. Next slide. Feel free to write any questions in the chat or anything if you have any thoughts. So we'll talk next about the clinical presentation of cholera. Cholera is a GI bug, and actually, despite the dramatic presentation of people with severe cholera, mild cholera or cholera is often mild and often asymptomatic. So as much as 80 to 90% of people will be asymptomatic or have sort of a mild gastroenteritis, and then 10% will have more severe disease. So people with mild or severe disease will have diarrhea, abdominal discomfort, rumbling in their intestines, vomiting. What they won't have is really severe abdominal pain. They ought not to have bloody diarrhea, and they ought not to have true fevers. Real fevers should spark a search for some other source of infection or some other non-infectious cause of fever, but cholera is not classically associated with fever. And the incubation time is on average 2 or 3 days, but can be as little as a few hours and as much as 5 days. So that's the time from when the person somehow ingested the cholera inoculum to when they become ill. So you can imagine with the incubation of up to 5 days, and with so many people asymptomatic, that's how you can have the inadvertent exporting of cholera from one place to another, as we saw when it was imported into Haiti. Probably, you know, people who had caught cholera somewhere else came with the UN security forces and then shed that bacteria in Haiti. Next slide. Okay. Oh yeah. Borborygmi, which is a harder to say, is a feeling of one's tummy rumbling. Yeah, thanks for asking. And okay, let's talk a little bit about the diarrhea, because diarrhea from cholera has a very classic appearance. Does anyone know? Oh, Dr. Frank has taught us the Spanish way of saying this, borborismo. That's more easy to say, actually. Maybe I'm saying it wrong. Anyone know what the diarrhea looks like in cholera? Very watery, yes. Clear, yes. Más o menos, yeah. Anyone else? What does the diarrhea look like? We said there was no blood, so you shouldn't, don't say blood. Anyone else? So I have watery, clear, and another clear, I think, rice water. Yeah, rice water. What is rice water? Anyone? What does that mean, rice water?
When you rinse your rice out and the leftover, I forget what it's called, but the leftover from the rice makes your water like rice water.
Like whitish. Yeah,
Yes,
exactly.
yes.
Yeah, so like this picture. Next slide. So that is not rinsed rice. That is stool from a person with severe cholera. So they might have brown colored stool at first, and then after that, it can just look like that, which is, I think, an almost unbelievable thing, because that doesn't look like poop at all, but really does happen. So you basically have really high, in severe diarrhea, and severe cholera, excuse me, really high outputs of stool that looks like that. And people with severe diarrhea, severe cholera, can have 1 liter an hour of stool output. So they can lose 10% of their body weight before they even arrive to the hospital, even if they've arrived quite quickly. It's very dramatic. People show up having become very dehydrated in a very short amount of time. So they'll have dry mucous membranes, sunken eyes, clammy skin, decreased skin turgor. So that means if you pinch the skin, usually on their abdomen, it doesn't like spring back as quickly. Washerwoman's hands is like hot tub hands. You sit in water for a long time, they become wrinkly. The person can look like that. Small breathing, which refers to the deep breaths that we take if we have a metabolic acidosis, as our body attempts to compensate and breathe off CO2. You'll notice that I didn't anywhere in here write any vital signs. I didn't write any lab abnormalities or lactate levels or anything. And that's because this is really a disease of impoverished, resource-poor places. And so if we had cholera cases at Denver Health, we would have unbelievable amounts of data about each patient. But the reality is that in places where cholera usually occurs, that type of information is usually not available. And so assessments are made on the basis of vital signs sometimes and on clinical exam. And in fact, like if you look at the WHO or Doctors Without Borders treatment recommendations, two big organizations that take care of patients with cholera, with the exception of pregnant women, vital signs don't even make it into the assessment guidelines. It's all about these physical exam things, and lab values certainly don't make it into the assessment guidelines. Let's see. So without treatment, people with severe disease, so not the mild disease who get better on their own or have a little bit of gastroenteritis, but that 10% with severe disease, without treatment, the reported mortality rates are 50 to 70%. So, and most of those people die at around 12 hours from disease onset. So the people that, and that 12 hours comes from some data in Haiti from the recent outbreak. So the people that don't get care in time, 12 hours from onset of diarrhea to death from hypovolemia. Next slide. So if you do have the luxury of getting lab tests, you would find things that you would expect to find in a large volume of diarrhea patient. You would find some hypokalemia. You might find some sodium abnormalities, although it can go either way, and a lot of people have normal sodium levels. You might find hypocalcemia. You might find an acidosis, which is both a non-anion gap acidosis from diarrhea and bicarb losses, and also an elevated anion gap acidosis from lactic acidosis. Some people who don't get resuscitated in time would get renal failure from acute tubular necrosis. And some people, especially kiddos, can get hypoglycemia. That's probably the one thing that you would be able to test for in a resource-poor setting. I included the EKG as a reminder that these data are probably not available in the places where cholera patients are most commonly found. So the ECG might be something you could get even if you couldn't test the potassium level more directly. So the person in this ECG had a potassium of 1.9. You can see there's ST depression, T wave inversion inferiorly, U waves, and a very long QU interval. If you look at the I think WHO and Doctors Without Borders guidelines for when to supplement potassium in patients with cholera, it's completely based on symptoms, not even EKG, and definitely not basic metabolic panel. But obviously, if we saw these patients at Denver General, we would just test their potassium level and give them potassium chloride if it was needed. Next. So how to diagnose cholera? There's a couple of things to think about. There's the WHO case definitions, and then there's the WHO recommendations on when to suspect an outbreak. So you can suspect a case based on a couple of criteria, and then you can confirm that case based on testing. So you can suspect a case if there's not been an outbreak, and you basically have two people living near each other with suspicious diseases. So two people living near each other who in the same time and place develop a severe diarrhea causing death or dehydration. That should make you suspect that they might have cholera. Or if you know that there's an outbreak in this place, and then a person comes in with severe dehydration or death from watery diarrhea, you should suspect them to have cholera. And then you confirm that infection with testing, which is fairly obvious. You guys know the definition of acute watery diarrhea that the WHO uses? You can write it in the chat. So it's just 3 or more loose or watery stools in 24 hours is the definition that they used. Okay, so next slide. There's a couple of different ways that WHO recommends that we have a cholera alert or suspect a cholera outbreak. And this is so important because cholera outbreaks happen swiftly. Remember that the stool shed from the people with cholera is highly infectious. The whole reason they got it is probably that they're living in a place without good supply of drinking water or good sanitation facilities. And so it's really important to go from concern that a person has cholera to concern that there might be an outbreak to responding to an outbreak, it's important that systems be able to do that quickly in order to prevent unnecessary death. So the WHO recommends that we suspect a cholera outbreak if 2 or more people die within a week of each other from acute diarrhea, if one person who's a little bit older dies from acute watery diarrhea, or if there's one confirmed case in a place where there hasn't been confirmed cases. So the interesting thing is all it takes is a death in an older person to make you concerned that there's an outbreak, and that should reinforce the idea that cholera is unique in causing death swiftly from dehydration from diarrhea. Okay, so next slide, please. There are a couple of different types of tests that are used to diagnose cholera. It's interesting, PCR, I don't think is very commonly used practically, and if you read about it, it seems to be only used in research, although it is used in the WHO definition of a confirmed case. But I guess if you had a PCR, then you would know that they had cholera. But and dark field microscopy is also quite sensitive, but not specific. If you see the cholera swimming across the field, then you can be pretty certain that it's there, but it's not very sensitive. So the 2 tests that are really more practically used are culture and rapid diagnostic antigen tests, or RDTs. And again, to drive this home, this is usually in a resource-poor setting, and the first test that's usually used in these settings are the rapid diagnostic tests. I think we have all become much more familiar with these because of COVID, but they're used for all sorts of diseases, for pregnancy. The rapid diagnostic antigen tests for cholera are little strips of paper with a little pink line or blue line or something for the control, and a second little line that if the cholera antigen is detected. And they can be done by a very minimally trained person in a very short amount of time. And there's a couple of different brands. This picture here is the kind that I've used, and it detects both the O1 and the O139, so both of those groups that can cause cholera, whereas there's another brand, I think Colkit or something, Colkit, that detects only the O1 antigen, but at the very least, this brand detects antigens from both serogroups. And then the recommendations are that a positive antigen test should then be confirmed by culture. And culture not only is the gold standard, but also obviously can be used to look for antibacterial resistance and susceptibilities, which, as you would guess, is important as with most bacterial diseases. One interesting thing is that the recommendations from WHO are still to use culture to confirm RDT, at least in a new outbreak. And RDTs are still listed as only 90% sensitive and 85% specific. But there are some data to suggest that that might actually be because culture is less sensitive. And culture might be less sensitive because people who have already received antibiotics, or people who possess a lytic bacteriophage, a virus inside of them that attacks bacteria, might have false negatives. So in other words, maybe your patient has a positive antigen test, so you send off their sample to some lab somewhere far away, and 5 days later you get a result that says their culture was negative. And using the gold standard of culture, you would then assume that your antigen test was a false positive. But actually, it might be the case that your antigen test was a true positive, and your culture was a false negative, maybe because you already give them antibiotics by the time you'd sent the sample. So culture is just a little bit less easy to interpret than maybe you would hope, but still important because of the ability to get sensitivity and resistance patterns. Do you guys have questions about that? No? Okay, next slide. So the differential diagnosis for mild or moderate disease is basically the differential for non-bloody diarrhea. In places where cholera is endemic, in adults, that's most likely to be ETEC, enterotoxigenic E. coli. And in kiddos, it's most likely to be a rotavirus or cryptosporidium. But, Campylobacter and norovirus, all sorts of viruses and bacteria can cause a watery diarrhea. And in a person with mild or moderate illness, it's impossible to distinguish clinically, but you can distinguish a little bit epidemiologically based on current outbreaks. And then in severe disease, again, cholera is unique in the severity of diarrhea and the fact that we can see rapid progression to death, especially in adults. Little kids and malnourished little kids can die from other causes of watery diarrhea. Adults are less likely to, and especially in endemic settings, should make us think of cholera. Next slide. So, diarrhea causes death in cholera, and the treatment is fluids. We can talk about antimicrobial resistance and antibiotics and vaccines and vitamins and all sorts of things, but the treatment of cholera is fluids. Next slide. Okay, what type of fluid is best? No Googling. You guys know some fluid types. Okay, we have a vote for normal saline. We have a vote for sugar, salt, water. Anyone else? Oral with electrolytes. Anyone else? Dr. Hollis, what do you mean by sugar, salt, water? Dr. Frank says WHO rehydration. Yeah, oral rehydration solution or oral rehydration salts, actually. Yeah. D5 half NS with 20 of potassium. I like the oral way before IV. Okay, so we have some votes for the WHO oral rehydration salts and for oral fluids with electrolytes, which could be the same thing. We have something in Spanish that I won't try to pronounce because it'll make me look like an idiot. But you can read what Dr. Frank wrote there. Okay. Good job. We have a vote for D5 half NS with 20 of potassium. Cool. So there's a lot of kind of fluids, right? The short answer is that most types of fluid are probably better than nothing, but there are definitely things that are better than others. And this is a question that has been studied. So depending on the severity of illness, you're either going to have IV fluid or oral fluid. And we'll get to that in a minute. But first, we'll talk about how to decide if you have going to do IV, which IV, and if you're going to do oral, what kind of oral fluid. So next slide. Okay, if you're going to do IV fluid, lactated ringers is best. That is what has been shown to cause the best outcomes in people who need IV fluids for cholera. And whoever said that, somebody said they prefer oral over IV if possible. Maybe Dr. Richards. I don't know if you guys have ever tasted the oral stuff. Based on taste, you will not prefer it. But you're right that based on a sort of treatment of mass numbers of people, it's best to use oral if possible. But we'll get to that in a minute. So if you're going to use IV, lactated ringers is best. Remember that there's some potassium losses in cholera, and potassium, lactated ringers has a little bit more potassium in it. But if you don't have lactated ringers, normal saline is fine. And again, remember that at Denver Health, we always have a bajillion liters of lactated ringers in every trauma bay, in every room, in every med cart. But there are a lot of places where that's not true. So lactated ringers is best. If you don't have it, normal saline is good. D5 and normal saline is also okay. Hypotonic fluid is not good because of the amount of salts that are lost. So these people should have a isotonic fluid, like lactated ringers, like normal sol, if you've ever heard of that, which no one has, like normal saline. There are even these locally produced IV fluids that are made in places where there's more cholera that are supposed to more accurately replace potassium and glucose. Like there's one called Dhaka solution. Dhaka is the capital of Bangladesh, which is one of the places where there's the most cholera. And Dhaka solution, I think, has extra potassium and some glucose in it. I have taken care of patients with cholera in Bangladesh, and I've never seen this stuff, but I believe that it exists. But most of the time, you're going to use lactated ringers. For the people who, like Dr. Richards said, for the people who can take oral, the best is the WHO oral rehydration salts. There are different companies that market these in little packets, and the little packets are usually meant to be dissolved in a liter of water, clean, treated water, obviously. But some are actually meant to be dissolved in different volumes of water, so it's good to take a look at the label. And those have sodium, potassium chloride, citrate, and glucose in certain amounts that are supposed to approximate the volume losses from the cholera diarrhea or other causes of acute watery diarrhea. It can be confusing because some places you'll see this referred to as low osmolar ORS, and then you'll read it and say to yourself, well, what's the regular osmolar? Why am I choosing the low osmolar? It's low osmolar compared to what the WHO used to recommend. So they changed their recommendation like 2002 or 2003 to one that's a little bit lower sodium, lower osmolar, and this is supposed to, or it has been shown to decrease stool output a little bit and decrease vomiting a little bit. It also was shown to be associated with some mild hyponatremia, but that's supposed to be subclinical, like not really important clinically, and gets better on its own. In a pinch, broth is okay. Even water is okay in a pinch while you get the person to care. High sugary drinks like sports drinks, which are advertised as having electrolytes in them but have a ton of sugar, are not okay. They're too much sugar. They can actually worsen diarrhea and don't approximate this sodium loss as well. I mentioned this a moment ago. I don't know if anyone else on the talk has ever tasted oral rehydration salts. Anyone? It tastes like seawater. It tastes like going swimming in the ocean. It's gross. Maybe Dr. Frank likes it. I think it tastes gross. But I remind myself of that when I remember not to use Gatorade or something. Yes, gross, so gross. So it's really quite different than Gatorade. It has a lot more salt and a lot less sugar. I have pitied the patients to whom I prescribed it. Interestingly, I've been told, and this isn't based on data, this is just based on anecdotal experience. I've been told that people who are really dry, like from cholera, which I have not experienced, crave it in a way, and so it tastes less gross to them. But I'm not sure because I've had patients reject it on its grossness. And I've also been given some tips for getting little kids to eat it. Like, I don't know if you've ever made homemade popsicles for your kids where you freeze a little stick in like a paper cup, but I've seen this made into popsicles for little kids. So they just constantly look on it and maybe trick them into taking it that way. But it's disgusting. Yes. Dr. Richards has seen babies suck it down. I mean, I've seen people drink it too, but I've seen people reject it. Yeah. So Gary, maybe the craving. Okay. I have 17 minutes. Better get going. Okay. So the treatment, remember, is rehydration, and it's, oh, next slide, please. Sorry. Is based on the severity of disease. Again, note that this table, which is basically the recommendations of WHO and Doctors Without Borders, which are two large organizations that treat these patients, don't have any vital signs or labs on them. It's all based on physical exam. So based on those other, on those criteria that we discussed a little while ago, you're going to assess their degree of lethargy or their degree of pulses, their sunken eyeballs, their skin that doesn't go back properly when you pinch it on the abdomen, and decide how dehydrated they are. Little kiddos can sometimes have eyeballs that always look sunken, so you might ask the parents if that's what their eyes usually look like. And elderly people can have skin that doesn't go back easily when you pinch it, and sometimes instead of pinching the abdomen, pinching the area just below the clavicle can be helpful. So based on whether you think your patient is not dehydrated at all, but sick with cholera diarrhea, somewhat dehydrated, or very dehydrated, you're going to go with plan A, B, or C for volume resuscitation. And if you start and realize you're wrong, oh my gosh, they're more dehydrated than I thought, they're going into shock, they've lost, their radial pulse is barely palpable, they're unconscious, they're hypotensive, then you might switch. If you started at some dehydration, you would have to switch to severe. Next slide. So people who aren't dehydrated but have diarrhea from cholera should get plan A, which is basically oral rehydration salts to approximate the fluids that are being lost. And for adults, we're looking at like 250 milliliters for every loose stool, which if you had 8 loose stools in a day would be 2 liters in a day. And if the person is asking for more, we should give them more because their thirst is probably a signal that they need more, and maybe they're craving it, like Dr. Richard's kiddos. Okay, next slide. So plan B is for people who are somewhat dehydrated. So their pulse is okay, they're awake, but they're like looking a little dry and wrinkly, or if you have vital signs, then they have vital signs that seem to indicate some amount of dehydration. Those people should get, for both kinds of dehydration, moderate and severe, the principle is they get a bolus while at the same time and afterward get fluids to replace their losses. So in moderate dehydration, the bolus is oral. It's 75 milliliters per kilogram over 4 hours, and at the same time and afterward, additional to replace their losses using the table up from a moment ago, so 250 after every loose stool. So 75 milliliters per kilogram for 165 pound, 75 kilogram adult is 5.5 liters over 4 hours. Plus you're giving them an extra after every loose stool. They could easily take in 6.5 liters in those first 4 hours. Kind of a lot. Okay, next slide. Then if your person presents with severe dehydration, that's when you're going to use IV rehydration. Or if they have such profuse vomiting that they're not keeping down the oral in moderate, then you would use IV. But for severe dehydration, for an adult, you're going to give a bolus equal to 100 milliliters per kilogram that is done by 4 hours. And 30 milliliters per kilogram of that is going to be in the first half hour, and the next 70 is in the next 3 hours. So for that same kind of moderate sized adult that we mentioned a minute ago, he or she's going to have 2.25 liters in the first 30 minutes and 5.25 liters in the following 3 hours. And you're going to compensate for ongoing losses. If they're already able to drink, you can do it with oral rehydration solution. And if they're not, you're going to do it with more lactated ringers. So if you imagine trying to give 2.5 liters in 30 minutes, you're going to need 2 lines. Plus, if you lose 1 line and your person is this dehydrated and in shock, then they're going to die. So people that come in like this should get a big line in each arm, like you're a person that you're resuscitating with hemorrhagic shock. And then you can calculate it such that you give the 2 boluses simultaneously to finish everything in 30 minutes. The recommendations are that if you spend 90 seconds and can't find a place to get an IV, that you should move on to an EJ, to a scalp IV in a baby, to a intraosseous line. So we really shouldn't lose time in our patients with shock, because remember, they have maybe 12 hours from onset of diarrhea to death if we don't take action and start IV fluids. So let's say you give your 30 milliliter per kilogram, 30 cc's per kilogram bolus, but they still are in shock, you can repeat that bolus. Or if you finish the entire 100 cc's per kilogram, but they are looking bad again, you can repeat. And that is definitely needed in some patients. At some point, they'll improve, and then based on your assessment, when they've improved, you can move on to plan B, a little bit more oral bolus, or plan A, just replace the losses if they are looking like a lot better. People who are just needing plan A without dehydration can probably just be monitored for a couple of hours, as long as they can go home and properly follow instructions and they can get back to the hospital easily, whereas these folks are going to need to be admitted, obviously. Okay, next slide. So just to remind us, this is a lot of fluid. Once you take into account the boluses, the additional that you're replacing because of ongoing losses, the need for some people to have repeat bolus, the average amount of fluids needed for someone with severe cholera in the first 24 hours can be 200 milliliters per kilogram, which for our example adult is 15 liters. And for some people, we're going to need up to like 350 milliliters per kilogram in that first day, which is 26 liters for that sample adult. So it can really feel kind of strange to be continuing to order or give all of these fluids. It feels like a lot, but it's what's necessary when people have these losses. The picture I just threw in there is of a cholera treatment center that's pretty representative of one in the developing world. So there's this like cots with holes in them and the buckets underneath. because people are often so sick that they can't get up to the toilet and having so much diarrhea that it's coming out like constantly into the buckets. Slide. So remember, severe disease, untreated, up to 50 to 70% mortality, but that ought not to happen. With volume resuscitation, it ought to be less than 1%, and some sources say less than 0.2%. So these people are really, they should walk out of the hospital in a few days if we treat them appropriately. Next slide. So fluids. Fluids are the most important treatment, but there are other things too. Next slide. There are antibiotics that are useful against cholera. They shorten the duration of diarrhea, they decrease stool output, they decrease the amount of bacteria that are shed in the stool, which can help make people less infectious. And they're given as single doses, so it's pretty easy. And the 3 antibiotics that are sort of shown to be effective and are recommended by multiple different organizations are shown here: doxycycline, azithromycin, and ciprofloxacin. This is another place where the American and international recommendations differ a little bit. So the recommendations in the United States, I think, are to start with azithromycin, but a lot of other places are to start with doxycycline. Doxycycline is a lot cheaper. Doxycycline does have more resistance than azithromycin in a lot of places. So ideally, you would send off your isolate for culture and sensitivity. Then you would know the sensitivity of your patient's isolate, and then you would choose an antibiotic. But in reality, that data might not be immediately available. The next best thing would be to know the sensitivities of an isolate from a person involved in that outbreak. So if you have 20 people in the neighborhood that all had cholera, and one person had an isolate sent for sensitivities that was resistant to doxycycline and then sensitive to azithromycin, you're probably going to assume that everyone has that isolate, and you're going to give them all azithromycin. And that's how their recommendations are written, to send a certain number of isolates every so many days, weeks, or months to estimate the resistance patterns of the community. And then again, because there's often drug shortages and because it can be hard to get people antibiotics at the right time, usually antibiotics are just recommended for people with moderate to severe disease. Does anybody here know whether or when we should give antibiotics to people that haven't been shown to have cholera, but to prevent it? Kind of a leading question, maybe. Like if your sister and you are like sleeping in the same cot and she has cholera, should you take a dose of doxycycline to help prevent you getting it? This comes up a lot.
Seems like a good idea.
Huh?
It seems like a good idea.
It does seem like a good idea. So this is still done in a lot of places in immediate families and in neighborhoods and communities, but the recommendations are not to do this usually, mostly because probably by the time you've done it, the deed is done. Probably the person has already been exposed by that time, and it probably also increases resistance of cholera and of other gut bacteria. Like ciprofloxacin is used for all sorts of other infections. So the current recommendations are only to use it in super crowded type of places, prisons, orphanages, other like institutional settings. But I've seen this come up a lot, and I've seen a lot of misinformation, like people doing this maybe when they ought not to, which might be contributing to the high rates of doxycycline and resistance. And little kids, which I don't think much about little kids as an internist, but zinc, a 10-day course of zinc for cholera and for other diarrheal illnesses can help their recovery and help protect them against future diarrhea. Next slide. So vaccines are cool, but clean water is cooler. Really the cornerstone of cholera prevention, and the reason why we don't have cholera and don't need to take vaccines in the United States is that we have clean water systems. So the CDC, WHO, Doctors Without Borders, all of these organizations produce materials and recommendations for creating systems of water sanitation, of waste disposal, for distribution of soap and other resources. And we could talk for a whole hour about that. There's a couple images. Next slide. So like here's a CDC infographic on purification of water using household bleach, which is the most commonly used substance. Next slide. And here's one also by the CDC about sort of proper disposal of waste, how we should bury our waste a certain distance from a water source. Next slide. And here's one from the CDC in Haitian Creole, just for fun, about hand washing, proper protocol for hand washing and when we ought to wash our hands. So these organizations that respond to cholera outbreaks have entire branches that are devoted to water and sanitation, because that is the most important thing to quell an outbreak. Next. So we have 4 minutes. Vaccines help to prevent in the short term against cholera and are useful to protect for months to a couple of years for certain people, but are not widely distributed to travelers and are not widely distributed even in places where there are sometimes cholera outbreaks. So they're really only used in certain settings. We can talk more about it, but I'll leave a couple minutes for any questions. Or comments. Thanks for coming.
Martina, this is great.
Oh, good. Thanks.
Sorry, I'm off camera.
No
But
worries. I know what you look like.
I had a stroke alert call on one of my patients, so I may have to leave.
I'm sorry.
But this was amazing.
Good.
Yeah, Dr. King, I think if people are thinking of questions to put in chat or come off of mute, I did have one question. You mentioned earlier in the presentation that immunity leads to a better prognosis in these cases. Are there sort of different levels of that? Like you mentioned that to have severe disease, people have to ingest quite a bit of the bacteria.
Yeah.
So at lower levels, is there still some immunity but less, or how is that scaled?
So maybe there's two different things there. There's what inoculum you need to ingest to get sick, and then there's immunity that you have from prior infections or from vaccination. So if you're asking, do people get less sick if they ingest a lower inoculum? I would think so, but I can't actually point you to those data. If you're asking, are there different amounts of immunity? Like, do people maybe get sick but not as sick? I think the answer is yes. So like the trial for the cholera vaccine that's distributed in the United States, VexCora, they actually gave 197 volunteers, half of them placebo and half of them vaccine, and then they ingested the cholera. They gave them cholera, and the recipients, some of them still got cholera, but many fewer did. So I don't know if that answers your question, but like it's like not perfect immunity, but does lower the chance of getting sick and of getting really sick.
Yep,
Yeah.
that makes sense. Thank you.
I don't know how much they compensated them for being in that trial, but I would ask personally to be compensated.
Right.
Yes, Adam.
Martina, that was great.
Yeah, hi, Dr. King.
Everyone's talking at once.
I have one question.
Adam first.
Oh, Dr. King, I was going to ask, with your experience, have you seen any IV subcutaneously?
Can't hear you. Can you type it in the chat? It's like breaking up a lot.
Yeah, Adam, if you're able to put that question in the chat, and then Dr. Hollis, I think you had a question as well.
Yeah, that was great. So I noticed on the oral rehydration salts, it said you can't boil them. And I'm just curious as to why you can't boil them. Because boiling water sounds good for at least cleaning it somewhat.
I agree with you, and I have a theory, but not a definite answer. So boiling is good for purifying water. It's also kind of the last type of purification that WHO recommends because it takes so long and requires a lot of energy. So only if you don't have a proper chemical way are you supposed to boil. Or interestingly, if the community is already really used to boiling, then you shouldn't go and try to change their practices right during an emergency. Boiling after you add the salt, my guess is that, you know how like if you boil salty water, then a certain amount of the salt like precipitates out. So my guess is that if you boil it after you add the salt, that you might end up with like a less saline solution or something, but I'm not sure. I have seen cats receive sub-Q fluids, and I have heard of giving it to adults, but I have never personally done that.
So I'm gonna say I have given sub-Q fluids to adults, but never with cholera. So not like 20 something liters in like 24 hours. So I have done sub-Q, but don't know how you do it with those many liters.
You think it would be hard to give that volume subcutaneously?
That much? Yeah, it will take a long to absorb, but I don't know. It would be interesting to know if maybe they can do it. Granted, when somebody's in shock, it's going to be very, very hard to find a vessel.
Yeah.
So finding alternative ways. So there are some studies, but I don't know. I have done it here, but never. It wouldn't even occur to me to use it for that. Volume,
for me, the thing that occurs if you can't get a vein is an IO. Good question, Adam.
All right. I'm not seeing any other questions in the chat, but certainly if people think of any additional, pop them in the chat or send us an email and we'll follow up afterwards. Dr. King, anything else that you wanted to cover?
So thanks for coming.
I'm gonna say thank you, Dr. King, for being the first speaker in our new and revamped Funky Bug series. So thank you very much. This was a pleasure, an honor to have you, and it was a great start of the new series.
Thank you.
Yep, I'll echo that as well. Dr. King, really appreciate your time in this presentation. I thought it was really informative. For better or worse, I'm going to think about cholera every time I rinse my rice now.
Delicious.
Everybody, if you do have questions that come up after the presentation today, feel free to send us an email. Our team email is hitteam@dhha.org, and we'll be sure to get those answered. And stay tuned for information about our next presentation, which will be Friday, October 20th at the same time. We'll have some representatives from the emergency management department here at Denver Health talking about emergency management related to special pathogens and biocontainment. Thanks everybody for attending the call today, and have a good rest of your days.